Bismillah ar-Rahman ar-Rahim. At the beginning, I'm grateful to Professor Initial Tut and the committee of the Congress for inviting me to participate in the activity of the conference. Also, I'm grateful to Merck for their kind invitation to present their symposium. My talk today about step 1 for diabetes management. Metformin story in 100 years. Metformin is 100-year-old. Metformin in 1922 first synthesized in Germany. In 1950, physician Garcia used it to treat influenza and discovered it can lower blood sugar and is not toxic. In 1957, in 1957, French physician Jean Sterny reinvestigated the blood sugar lowering effect of metformin and introduced it as treatment in diabetes in France. Metformin was introduced in United States in 1995. Adding to the story of metformin, Glucovage XR or Metformin XR was approved by the FDA in 2003. As we see, there are 3 dates: 1922, 1957, and 2022. In addition to the comprehensive modification. Comprehensive lifestyle modification, metformin is the first antidiabetic agent in most people with type 2 diabetes in all guidelines until now. As you see, ADA, ACE, ASD, Canadian, NICE, and Australian. What is the mechanism of action of metformin in treating diabetes? Briefly, it decreases hepatic glucose production, decreases intestinal absorption of glucose, and it increases insulin sensitivity. It promotes uptake of glucose by the peripheral tissues. Other effects as increased GLP-1 and alteration of intestinal microbiome. Other effects away from its glucose lowering effect, anti-inflammatory effect, vasodilating effect, anti-aging. All are these beneficial effects for glucovage or metformin. Mr. Ahmed is a 45-year-old newly diagnosed with type 2 diabetes. How will you start managing this patient? According to the ADA and different guidelines, now we have to determine first the glycemic needs of the patient. Glycemic needs mean his A1C level and his A1C goal. Number 2, patient-centered treatment factors as cost of the treatment, accessibility to treatment, and other criteria in the patient. Also comorbidities as established cardiovascular disease, renal disease, or cardiovascular risk factors. According to the ADA 2022, first line of therapy depends on comorbidity, patient-centered treatment, management needs, and generally includes metformin monotherapy and comprehensive lifestyle modification. As Professor Asim mentioned, lifestyle modification is a fundamental part in the management of type 2 diabetes from before diagnosis, even before diagnosis, till the end of life. Regarding our patient, should we start with combined treatment? When A1C is 1.5% or more above his target, many patients will require dual combination therapy to achieve their A1C level. Glucovage can be combined with any other antidiabetic agents, including insulin. Also, as Professor Andrew mentioned, in the VERIFY study, the early combination therapy of vildagliptin with metformin was beneficial in keeping or in maintaining beta cell function and more effective reduction in A1C. Metformin is available as IR formulation, immediate release formulation, and is given twice daily, or extended release formulation and is given once daily. What makes metformin the first step in hyperglycemia management until now? Metformin has high efficacy, high A1C lowering action compared with other anti-diabetic agents, associated with no risk of hypoglycemia. It's weight neutral or maybe associated with weight reduction. It has other effects on cardiovascular system associated with potential benefit in cardiovascular disease, and neutral regarding heart failure. It's low cost. This is the guideline of ADA 22. As you see, metformin is suitable in all patients' profile is the initial therapy, in addition to comprehensive lifestyle modification in all patient profiles, whether the patient is obese, whether for economic factors, whether for risk of patients with risk of hypoglycemia. Even in patients with cardiovascular disease or chronic kidney disease, the cardioprotective drugs can be given with metformin as initial therapy if A1C needs dual therapy. This is a nice guidelines, and as we see, this is nice guidelines. First line of therapy, first pharmacological therapy is metformin. And if the patient is not tolerating metformin IR is shifted to metformin XR. Also in patients with cardiovascular disease, heart failure or renal disease, the same. Patients will, in the NICE, start on metformin IR if not responding or not tolerating GIT side effects of IR, shifted to XR, and then other drugs are added as sodium glucose transporter 2 inhibitors when indicated. In the KDIGO 2022, the first line of treatment of patients with diabetic kidney disease is metformin plus sodium glucose transporter 2 inhibitor in addition to comprehensive lifestyle. XR formulation provides better tolerability, better adherence, and so better metabolic control. As you see, Glucovage XR or metformin XR, the technique is gel shield diffusion system. As you see, there is external polymer. External polymer does not contain metformin granules. This is internal polymer, contains metformin granules. This allows slow release of the metformin in the GI and slow absorption, and so it covers 24 hours and its duration continues for 24 hours. So it is given once daily. Comparing patients receiving XR versus IR formulation as initial therapy showed significantly lower any GIT side effects or diarrhea with XR formulation compared with IR formulation. Also, patients who are switched from IR formulation due to GIT side effects showed reduction of any adverse GIT side effects by 50% and reduction of diarrhea by 50%. This is reflected, or this in other studies. This is a different study. This is reflected on better adherence, and so the better tolerability is translated to better adherence, and so better A1C reduction with XR formulation. What's regarding the efficacy of metformin? Metformin, compared with other antidiabetic agents, decreases A1C from 1 to 2%. It's comparable to sulfonylurea and is higher than other antidiabetic agents. This graph shows, how this figure shows the effect, glucose lowering effect of metformin at different doses, effect on fasting glucose and the A1C, and as you see, the higher the dose, the better the response. The ideal dose is 2,000 milligram is the optimal dose to reduce A1C by 2%. Here, A1C reduction by 2% at dose 2,000 milligram per day. This study about the effects of increasing metformin was carried out in patients receiving metformin 500 to 1,000 milligram per day and not controlled, and the blood sugar is not controlled, A1C above the target. The patients are randomized either to increase the dose of metformin or to combine DP4 inhibitor with the metformin or to shift to DPP4 inhibitor. The study included 494 patients, A1C 7 from 8%. Primary outcome was a change in A1C level at 12 months from the baseline period. As you see, increasing the dose of metformin was associated with better or more significant reduction in A1C compared with combining with DP4 inhibitors or shift to DP4 inhibitor. Metformin also has long-lasting control. In this study is a retrospective cohort study comprised about 15,500 patients, fully insured patients with type 2 diabetes in US, initially treated with metformin and other oral agents. The objective of the study to determine the effect of initial oral glucose lowering agent class on subsequent need for treatment intensification. As you see, after 388 days, only 24.5% of patients with metformin needed adding other agent versus 37% with sulfonylurea, 39% with TZDs, and 36% with DP4 inhibitor. At the end of the study, only 75% of patients on metformin will not need later second agent. In the study period, 388 days, and 95% of patients will not need later insulin during the study period. Away from the efficacy of metformin and the glucose lowering effect, we'll speak about cardiovascular benefits. In the United Kingdom prospective diabetes study, metformin, intense glycemic control with metformin in UKPDS reduced the risk of macrovascular complications in overweight type 2 diabetic patients. The group of patients in the UKPDS who are overweight and received metformin showed reduction in myocardial infarction by 39%, diabetes rate death by 42%, and any diabetes related death by 32%. Not only during the study period, these effects continued after in the 10-year post-trial monitoring period, and so a legacy effect, a good legacy effect was obtained with earlier metformin therapy. This is a real-world study, retrospective real-world study. They aimed to study the effect of metformin, a compromised patient with type 2 diabetes initially treated with metformin or non-metformin monotherapy. The targets of this study or the goals, primary endpoint was all-cause death, and in patients receiving metformin versus other drugs. ممكن patient receiving metformin versus non-metformin. The aim of the study was studying the effect of metformin on cardiovascular death and heart failure hospitalization. Both were significantly lower with metformin. Beyond treatment of diabetes, they are recommended in management of pre-diabetes in the DPP program, diabetes prevention program in America, was associated with 31 relative risk reduction in the risk of diabetes in patients with pre-diabetes, and so it's recommended it should be prescribed in patients with A1C more than 6, fasting glucose more than 110, BMI more than 35, and patients and young patients from 25 to 59 years. To summarize, Glucovage XR or metformin XR reduces progression to type 2 diabetes in patients with pre-diabetes by 31%. Is the first line monotherapy with reduction in A1C 2%. Has cardioprotective outcome, reducing MI by 39% in overweight. Also needs less treatment intensification than DPP-4 inhibitors needs less treatment intensification than DPP-4 inhibitors or sulfonylurea. Glucovage XR provides better GIT tolerability with Glucovage XR once daily formulation, and so this will provide better glycemic control. Thank you.
Thank you دكتور عمرو، شكرا على الإيرجنت توك. والدكتور رفعت برضه عايز تعليق بسيط.
شكرا استاذ عمرو على المحاضره الجميله دي. الحقيقه انا بقول دايما الميتفورمين از ذا كينج، فشرف كبير ان احنا نسمع منك على الميتفورمين، لان الميتفورمين ده اتحارب كتير، يعني من سنه 1957 وبدأ الميتفورمين يشتغل، والامريكان مش راضيين يعترفوا بيه لحد سنة 1995. وكان سببها حاجة ستادي كان اسمها اليونيفرسيتي جروب بتاع ستادي اوف دايابيتس، اللي هم قالوا الاخر انه ايه، هو مسؤول عن الهارت فيلير، هو اللي مسؤول عن حاجات كتيرة. وبعدين لحد ما جت، وبعدين جت بقى اليوكوبيديز والديس دي. اليوكوبيديز اكتر عشان استعملوا فيها الميتفورمين، لقوا فيها ان الميتفورمين بالعكس ده بيحسن الكارديو فاسكولار بعد الاناليسيس بعد كام سنه من اليوكوبيديز ستادي. وبعدين النقطه الثانيه ان السايد افكت تكاد تكون قليله، خاصه مع الاكس ار اللي هو ظهر في الفتره الاخيره دي. طبعا هو ليه الكينج؟ هو بيشارك كل ادويه الديابيتس، يعني نمسك من كل ادويه الديابيتس even the insulin، فده يعني شيء عظيم ومش هنسيبه ابدا حقيقي يعني. شكرا
شكرا جزيلا دكتور عمرو، شكرا. السيشن اللي بعد كده